We wanted to see how ketamine measured up when we integrated it into part of our surgical analgesia plan, specifically for rats.
Welcome to The Last Word, the official JAALS podcast dedicated to connecting and informing the laboratory animal science community. Each episode takes a closer look at recent articles published in our journals, JAALS and LAS Pro, and features interviews with professionals advancing the field. I'm Jennifer Smith, your host. As a laboratory animal veterinarian and the Director of Education and Scientific Affairs at JAALS, I look forward to sharing these conversations with you. Let's discover something new together. In this episode, I am joined by Dr. Rachael Alionhart. She is a clinical veterinarian with the Department of Comparative Medicine at Oregon Health and Sciences University. Rachael recently completed her lab animal training program and has a DVM and MS from the Cummings School of Veterinary Medicine at Tufts University. So today, we are going to discuss her recent JAAALS-accepted paper, titled The Effects of Subcutaneous Ketamine on Postlaparotomy Analgesia and Behavior in Female Sprague-Dawley Rats. Whew, that was a lot. Rachael, thank you for being here and for putting up with my slow reading. I am so thrilled to talk about your paper and really thrilled to meet you. That's the best part of this job, is meeting new people. And as I say over and over, I love meeting people that are on the rise. So I think Rachael is someone we're going to hear from again and again. So I am thrilled to introduce her to you guys on the podcast today. So Rachael, just tell us a little bit about yourself, please.
Yeah, no worries. And thank you so much for having me.
Of course.
So, as you mentioned, I just finished my residency in July of last year. I'm now currently a clinical vet at Oregon Health and Science University in Portland, and I've recently accepted a part-time position at the University of Oregon as a clinical vet for their animal welfare services.
Wow, you are going to be busy.
Yes, I will be busy. But that's a problem for future me. So I became interested in lab animal medicine. I don't think I realized it until undergrad, because while I did grow up with like guinea pigs and fish and was interested in animals, I just wanted to do a science thing. And that's really when it came about. So in my undergraduate years, a job opened up doing husbandry and cage changing and cage washing for the mouse colony. I went to the University of Redlands in Southern California. And since I was majoring in biology, and I'm not afraid of mice at the time, they're just small guinea pigs with tails, and I've had guinea pigs. So I took the husbandry position, but then eventually did join the lab and perform research. So they worked with C58 mice as a mouse model of autism. So I did some projects with how does intranasal oxytocin influence maternal behavior or social behavior, used 3-chamber social assays. And so that was great. Undergrad, I became a research assistant at the U of O, did really cool mouse optogenetics, where if you shine a laser at a certain part of their brain, they think they smell something, which is super cool. Then I was like, should I do? I don't know if I really want to write grants. And so I worked with the veterinarian there, Kathy Snell, and actually got interested in veterinary medicine specifically. So after about a year frantically trying to get all the prereqs, that's when I decided I should probably go to vet school, and was accepted. And so I feel like just working with her specifically for navigating some issues with our mouse model and the surgeries and some things that came up post-op just really helped me in my path towards, especially for this paper where it's refinement for the well-being of the animals. So
I love it. Yeah, that was perfect. I love it. Thank you for sharing that. Our listeners, I think, really like to know who you are and why you undertook this particular project. So we'd love to hear more about that. What was your specific interest in this project?
So, of course, everyone during their residency must submit a first author hypothesis-driven paper. And so since I would like to benefit the animals, not just it will also help the humans, it'll also help research, it felt like something related to analgesia or anesthesia, or I was even thinking maybe enrichment would be something I'd be the most interested in. My mentor, Dr. Jennifer Kapanke, who's also on this paper, she was like, well, ketamine, We could look at ketamine. We had a few other things, but specifically at our institution, there are many researchers who, for one reason or another, can't use a multimodal pain plan for their analgesia. So usually because we use NSAIDs or opioids, one is contraindicated. So what about ketamine? That could work. So that was part of the reason why we went in this direction.
Oh, I love that. I mean, there's always a story behind these projects, right? And I'm glad that you kind of throw out there, it's a part of being board certified. It's something that I know myself many years ago was fretting over, and thankfully had an amazing mentor. Shout out to Brad. He was a veterinary pathologist who kind of mentored me through an anesthesia project, not at all related to his line of work at all, but he was willing to say like, hey, you need to learn how to do research the right way. So come on, let's do it. So shout out to all those mentors out there. It sounds like you've got some good ones where you're at. And I can't say enough about that. Yeah, that's great. And I'm glad. This sounds like a great project right up our listeners' alley as far as analgesia. And I love the, like you said, the welfare implications from this study as well, which I know we're going to jump into. I'm excited to hear that. But just kind of keep in mind, listeners, this, assessment of pain is just as important as the drugs themselves. So I know Rachel's going to tell us a lot about that. All right. So we're moving on to the paper. Go ahead and tell us who worked on the paper. We know it takes a team, and we'd love to know who worked with you, who did what, any kind of juicy things you want to tell us about the team, or late night study sessions, data cramming sessions, whatever you want to share.
Yeah. So since it was my residency paper, I did a lot of the not so great fun stuff. So any of that late night stuff, that was me.
Yeah.
So I did the surgeries, evaluating the rats at each of the 8 cage side time points, setup of cameras, scoring the video footage. No one should want to do that. That was the worst part. But everyone else. So Alina White, our research and health technician, she supports much of the large animal surgical procedures here at OHSU. She was my assistant for the day of surgery. She did all the induction, animal, fur and skin prep, like the immediate post-op recovery. She also did the really important job of administering the analgesics that I needed to remain blinded to. So the extended release buprenorphine or extended release meloxicam, and either the ketamine or saline. And she also applied the fluorescent oil to the nape of the neck for the grooming transfer test that we also collected data on that I'll talk about later. Yes, I'll talk about that later.
Okay, good. I'm hoping you said you were going to talk about it.
So we also have Dr. Michaela Carlson, who at the time was my resident mate. She's about to graduate from the program at the end of June. So she performed a similar role as Alina during one of the pilots that we performed prior to the study, and helped Alina out for a few of the earlier surgeries when we're still getting our flow down. But since I was blinded at the time, she helped with drawing up all of the drugs per the rat treatment key that I was blinded to. So that important. Dr. Jennifer Kopinki, I mentioned earlier, was my mentor for the project. She's the head of clinical medicine and surgery for our department, obviously essential for the design and planning portion, the randomization of the treatment, pulling up the treatments, and consultation through the project, especially if animals reached a humane endpoint. And then finally, Dr. Kim Saunders, who's our director of our department, the attending veterinarian here, assisting with design, and of course, funding is very critical too. But everyone helped, of course, with the writing and reviewing of the paper. So that's
fantastic. I know you've got a great group there. So that's fantastic. Thank you. All right. Well, let's just jump into this introduction. It is good. And for anybody that just wants to know more about rodent analgesia, anesthesia, this is good, especially like I mentioned before, just the implications of how do we assess if this drug is working? So have at it, Rachel.
Cool. As veterinarians, I feel as though we're all taught in veterinary school that multimodal analgesia is usually the way to go to manage pain. Depending on the mechanism of action, that particular class of analgesic might be less effective to manage a certain type of pain, be it visceral, somatic, neuropathic, whatever. And depending on its efficacy in targeting that pain, you might need a higher dose of that pain medication for it to be effective, but if you even are able to manage it at all. So not to mention, if you use a higher dose, you have a higher risk of side effects, et cetera. But since different classes of analgesics target different parts of that pain pathway, the synergistic effects that you get through multimodal analgesia usually is better pain management while also not overdosing them and getting negative consequences with higher doses. So that's great. So Other than local anesthetics, which block the pain signal essentially at the source, like the two most common classes of analgesics used in research that I think of that first come to my mind are opioids and NSAIDs. At our institution, at least, these are usually buprenorphine and meloxicam. Could use carprofen, but usually I feel like meloxicam is slightly more often used here. But it's not uncommon for the use of one of them to be contraindicated for a study, like needing an opioid-naive animal for an opioid self-administration study, or if you need inflammation to establish a model, and so you can't use an NSAID because it would interfere. So that's where we were hoping ketamine might come into play. So ketamine is an NMDA receptor antagonist that in lab rodents, at least, is most commonly administered with an alpha-2 agonist like xylazine or dexmedetomidine for general anesthesia. But it does have analgesic properties, particularly for pain sensitization and wind-up, so like hyperalgesia and allodynia kind of stuff. Visceral and neuropathic pain can also be improved with ketamine. And so there's been more research in humans, but there is some promising studies in its ability to treat chronic pain and depression, specifically with subcutaneous subanesthetic doses of ketamine. So not enough to anesthetize you.
Right.
But as well as some of the companion animal vets I've spoken to, at least anecdotally, they've also found success doing a similar thing to treat chronic pain for some of their patients when other treatments don't work out. But specifically for post-op pain, there's some conflicting reports, at least in the human side of things. But in animals, at least for a couple of dog and sheep studies where when they integrate ketamine into their pain management plan, it improved outcomes. So since that hasn't really been explored super much in rodents, we wanted to see how ketamine measured up when we integrated it into part of our surgical analgesia plan, specifically for rats. So to do that, we needed to evaluate their pain and compare it between groups. So one of the most common ways is via a facial grimace score, where you evaluate the presence or severity of the animal's facial expression in terms of certain characteristics and compare it to a scale to estimate how painful the rat might be. There's also pain ethograms where you plug in their posture, appearance, activity, etc., and then into using it against this scale, and just based on the summation of rankings, you get a score that also should correspond to are they more or less painful. Other methods include time to incorporate nesting material, burrowing, food and water intake. But one that's just used in mice is called the grooming transfer test, where they apply fluorescent oil to the nape of the neck. And if they remove it quicker, meaning they groom more, it probably means they're feeling better, so lower pain levels. This hasn't been done in rats yet, so we figured why not? It's my residency project. I already had to be reeled back in for making it too big. Let's just do that too, in addition to looking at ketamine.
I love it. All right. Well, thank you for that introduction. That is very interesting. And I know we can't wait to hear more about the study design and then, the results. But tell us clearly what your hypothesis was.
Sure. So for our first hypothesis, if we used ketamine as part of a multimodal analgesic plan in combination with either extended release meloxicam or extended release buprenorphine, we thought that Sprague-Dawley females that received sub-anesthetic doses of ketamine for a midline laparotomy procedure would have improved post-operative pain control than those receiving just one of the extended release medications, and with saline essentially. So multimodal would be more effective than unimodal. We do have that second hypothesis too, which just involves applying the fluorescent oil. So seeing if that extinction rate of that signal could be used to indicate their rats post-op pain. So mostly the first one, but it's interesting to see if that second one also could work out.
All right. Well, Rachael, thank you for taking us through that introduction, and it's beefy, and we appreciate that. So for anybody that needs to know more about anesthesia and any of the sort of pain assessment modalities, that's a good reference for you. All right. So we're moving into materials. How was the study designed? And of course, we'd love to hear, just sort of more on how all these things came to be.
Yeah. So we had 4 different treatment groups. So we had 2 on a unimodal analgesic plan and 2 on a multimodal analgesic plan. So every rat received an extended release formulation of an analgesic. It was either BUPR, extended release buprenorphine, or Meloxi-R, extended release meloxicam. So half of each of those groups that each got a different extended release analgesic also either received, for each of those groups, half of them received ketamine and half of them received just volume match saline. So the treatment groups were meloxicam with saline, meloxicam with ketamine, buprenorphine with saline, or buprenorphine with ketamine. So those are the 4 groups. Since the midline laparotomy is a pretty well-established model, where previous research indicated that this is a painful procedure, we didn't want to do a saline-only control. And there's also some research to indicating, maybe not for this specific model, but that just ketamine alone probably wouldn't cut it. So just for welfare reasons, and we really just, based on what happens at our institution, this made more sense for the study design.
I love that. I'm just going to interrupt you for a second. I love that. And thank you so much for sharing that, because I think that's a really important part of designing studies that sometimes gets overlooked or, is just kind of not discussed. So I really appreciate that. And I applaud you and your institution, of course, for setting that straight, and as well as kind of sharing that with us and putting it in your study design.
Yeah. Now that you know what the treatment groups are, we had 32 8-week-old Sprague-Dawley female rats, Sprague-Dawley being the most common rat currently being used in research. So divide 32 by 4 treatment groups and you get 8 rats per treatment group. So as mentioned, it's a midline laparotomy. I did the surgery when you just open the rat up. I moved my finger around for about 2 minutes, closed them back up. But since I was blinded to the treatment groups, Alina was kind enough to do all the prep and injections. So each rat got either 1 meg per kg of extended release buprenorphine or 4 megs per kg of extended release meloxicam, and then either 30 megs per kg of ketamine or volume match saline. So we use 30 megs per kg since it's a sub-anesthetic dose. Several references use that dose despite 25 megs per kg being the minimum dose needed for antinociception. And then just because it fits here, we did also give 2 subsequent 10 meg per kg doses of ketamine or volume match saline at 24 and 48 hours post-op, just in case multiple days were needed for effect. And we did choose a lower dose because it's the most common dose for depressive behaviors, for relieving them in studies looking at that in rats. So just in case. And then finally, the fluorescent oil was also applied after the surgery, and we compared it to an anesthetized baseline that we evaluated a few days before the surgery. So post-op pain was evaluated in a couple different ways. One was via video camera, and then it was retroactively scored for pain behaviors for a period of 10 minutes of footage at 30, 90, and 150 minutes post-op. Looked for pain behaviors like back arching, staggering, orbital tightening, activity levels, licking, and stuff like that you can see via the camera. And then in real time, because you can't just leave the rats there and want to make sure they're actually not painful, we evaluated them at 8 time points. 3 hours, 6 hours, 12, 24, 32, 48, 56, and 72 hours post-op. So more traditional methods of evaluating for pain were also used, such as facial grimace. We had a pain ethogram that evaluated their weight, their posture, behavior, response to external stimuli. So me, since I was performing all the post-op evaluations, but we also assessed that grooming transfer test to see if that fluorescent signal, how long it would take to go away. And then also like how much food were they eating, how complex were their nests, just general post-op things. So that's the basic setup. I don't think I've forgotten anything.
Okay. Yeah, that is fantastic. Thank you. I mean, this is a robust study, so we appreciate hearing all of that. And thanks again for sharing the dosages and just all the information that you shared. Really is very helpful for anyone that wants to do something similar at their institution. It's time for a quick break to hear about the JAAALS Learning Library. Hey, are you ready to elevate your team's knowledge and skills in laboratory animal science? Well, the JAAALS Learning Library is your one-stop solution for comprehensive training. With courses designed for everyone, you can train your entire team in one place, earn valuable JAAALS CEUs and RACE CE credits, and take advantage of group discounts to maximize that investment. Getting started is easy too. Sign up for free to access select courses instantly to explore a vast library of resources. Empower your team. Stay ahead of the field and grow with the JAAALS Learning Library, your trusted resource for laboratory animal science professionals. All right. So now we know sort of how you did it. What did you find? Tell us about your results and, in particular, anything that surprised you.
Yeah, so I guess I can't really talk about this without talking about this part first, I guess. I can't talk about the results section without talking about this aspect first. So a lot of the big findings did come from the retroactive video scoring, which before even doing the statistics, since I was the one doing all the scoring, maybe astonishing or astounding aren't the best words, like maybe not unbelievable. I didn't really expect it, was that about half the rats appeared very comfortable. Like they were quite content with whatever analgesic combination they received. So I'm blinded. I kind of assumed at this point that these animals, because I've seen animals that have just received meloxicam and just received buprenorphine. If you pushed me, I'd probably say they probably looked like they received ketamine. But pretty much all these animals were very active. They weren't hyperactive, but they were steadily chugging around their cage with minimal to no pausing. They had virtually no orbital tightening, which would be suggestive of pain. But like in the composite behavior scoring system, staggering and back arching are usually indicators of pain. And these animals were doing a lot of that. They were constantly moving around, but like falling over while doing so. And because they were moving around so much, they had a tendency whenever they were in their square shelters that were in their cages to back arch whenever they turned around in them. And so if they're constantly moving, they're doing this more often, but they just seem so comfortable. So it was very interesting being like, I guess I can't really rely on some of these factors necessarily as much if they don't really line up with the animal. Like it was just interesting to interpret with this new information. So
yes.
After giving you that preview, but essentially the ketamine treated rats, regardless of whether they were given buprenorphine or meloxicam as well, just had higher staggering frequencies within their treatment groups at the 30 minutes versus the 150, so earlier on. Same with back arching. But there was no difference between their orbital tightening scores or their posture scores within the groups. And also the ketamine-treated animals appeared less painful than the saline-only controls that only had an extended release analgesic on board. The behavioral scores did improve for all the animals the further from surgery they were, except for the buprenorphine-only group. Theirs didn't really change for that variable, that factor. But also still talking about behavioral scores between the groups for those administered ketamine, they generally did better than the saline-only groups. Inactivity levels were low for the meloxicam ketamine group at all time points, but while in general the ketamine-only animals did look very comfortable, the inactivity levels did go up for the buprenorphine ketamine group at 150 minutes, but both were also significantly different from the saline-only groups at 30 minutes, so there's still that improvement earlier on, but for buprenorphine, that improvement didn't really stay consistent necessarily for all the aspects we measured. The meloxicam saline group here did also have improved activity levels at 150 minutes compared to 30. The buprenorphine group didn't. All these groups showed no difference in grooming at any time point, which was very interesting. Generally, when rats and mice groom, they start at like their nose, they do some cute little small circles, then they expand their little paws to encompass more of their face and then their ears, and then they move to different parts of their body like their back or their abdomen. So for grooming involving that motion, there was no difference at any time point between any of the groups. But whenever the animals were just licking their incisional sites, there were differences between groups. So we considered that different than a natural progression to that area.
That's very interesting. And I really appreciate you sharing that because I'm sure some of our listeners haven't done that yet or observed it. So I think that's great that you included it.
Yeah. So it's just very stark to be like, oh, look at that one grooming. And then for them to just not groom at all and just immediately go and lick their incision. So
yes,
only the ketamine-only groups showed the least amount of incisional licking at all time points. So still pretty comfortable between 30 and 150 minutes. And the saline meloxicam only group had significantly increased licking at 30 minutes, but otherwise seemed to improve as time went on further from surgery. But actually the buprenorphine only group, their incisional licking increased from 30 to 150 minutes. Like they had the highest rates of that. So essentially for the cage side in-person real-time assessments, there was essentially no difference in rats' pain ethogram or facial grimace scores between the treatment groups at any time point. There were some differences within the groups, but there was also In general, for weighing them, the rats with ketamine in their analgesic plan weighed more than those administered saline for a few of the time points, which we can talk about that a bit in the discussion, but they all ate pretty much the same amount of food, so that was interesting because we measured that as well. For fluorescence grooming, the meloxicam-only rats showed essentially no difference from baseline at any time point, whereas the meloxicam ketamine ones were the next quickest to return to baseline at 6 hours. But in general, until about 32 hours post-op, the ketamine-administered groups did have more delayed time to groom off their fluorescence. At a couple of time points, we had the non-ketamine-administered rats making slightly better nests, with meloxicam-only rats doing the best, essentially. But otherwise, I believe that's pretty much it.
All right. Well, thank you so much for that. Really great on those results. I mean, there's, like I said, there's a lot to this study, so I appreciate you summarizing that in chunks for us. So we'd love to hear just kind of your final sort of thoughts and your discussion summarily. What do you think?
Yeah, so at least for Sprague-Dawley female rats, for post-laparotomy pain, we'd recommend meloxicam extended release particularly. And ketamine works great with it. Like, ketamine does improve, it seems, at least for the first at least 90 minutes. For some aspects, 150 minutes. Like, it does seem to make them very comfortable. Like, they immediately post-op, it was very surprising how content and comfortable they were. Like, I do feel as though the rats that received ketamine were less painful in the immediate recovery period, according to several of the pain scoring characteristics that we evaluated. I guess it depends on your strain and your experimental model, but we would probably recommend against using buprenorphine, especially with ketamine, for certain procedures in rats, just because we also observed it wasn't enough to characterize and quantify, but there was a lot of pica that we observed.
Yep.
And it was especially prevalent in the buprenorphine-treated rats, just in general, regardless.
And I think anecdotally, that's kind of what's out there, right, in the literature. So I was really curious to see at the end of this paper if that's kind of something that you also saw.
So there was actually a large portion of my time went into collecting feces because I could see in their feces the amount of bedding. And I there was an attempt to make a scale, like a scoring chart, but there's also the variable, like it wasn't something I had planned for ahead of time. So it was, I guess, just for fun, I guess, as fun as collecting feces is, where you could see there's like some fecal pellets were literally just a piece of bedding. And it was like, oh, geez. But then again, we didn't test it ahead of time. We didn't evaluate what their baseline levels of pica were.
Sure,
but it did seem to inspire additional pica for the buprenorphine and maybe even also self-trauma, since we did have to euthanize 4 rats, withdraw 5, I believe. And so most of them did have buprenorphine involvement. And so at least for Sprague-Dawleys, maybe avoid. But for the fluorescence, it's somewhat a little difficult to compare it and say, yes, this correlates to like our cage side measures, because our cage side measures sort of didn't really show that there was much of a difference between the treatment groups at the like 3, 6, 12, etc. But then again, in person, I was interacting with the rats. They do modify their behavior. And so maybe correlating that with the video, using a video correlation to get a more accurate, non-human influenced measure of pain. While we do recommend considering ketamine in your post-op analgesia plans, if you had to, for at least Sprague-Dawley females, choose between meloxicam ER and buprenorphine ER, I'd say choose the meloxicam ER, just because regardless of like the pica and the self-trauma, just what we scored, they did seem more comfortable when it's used as a single analgesic method.
Yeah, and I think that's really important. I think that's a critical takeaway from your paper as well. So I'm glad you brought that up. You also did a nice job of describing some maybe limitations to this study, the way it was designed. And I would love if you could just sort of talk about using female rats versus male rats or both.
Yeah, so as mentioned, we only use female rats. Part of it was for like in the literature, I don't know if I addressed this a ton in the paper, but there have been a few conflicting papers, but it seems to be there's more evidence that if the analgesia is not going to work, it's more likely you might need a higher dose, or the pain might not be as well controlled for the same dosage as in females versus males, I guess, is without getting into receptors or things like that. So just because we didn't want to make our study huge and also add males in, we were like, well, females, we could just use females. Their analgesic plans, if it works for female, it should also probably work at the same doses for males. But also I did, for welfare reasons and looking into the future of this for after the study, they're females. They're more likely when I recombine them to be able to be group housed. And I did want to be able to group house them not only for welfare reasons, but also because this was not a permanently debilitating study for them. There was no hazardous materials. So we did adopt out 14 of the remaining 28 to members of the OHSU community. So we were able to do that. We could have probably done with males, but just for future compatibility as well, we thought it best to just use females.
Yeah, I love that. I love that you added that in because that's not always the end result. And I love hearing that. And I also love, just kind of hearing your forward thinking on the welfare and adaptability of one sex versus the other, which I think is a really important part of a study too, and very responsible. So thank you. All right. Well, we are at the end, and I'm sorry because I love talking about anesthesia, and I feel like we could talk for a long time, you and I. So we asked our guests one final question. So here is yours. I'm sure most of our guests now probably know what we're going to ask, but here's your special question. That is, what advice would you give somebody who wants to incorporate ketamine into their analgesia protocols, particularly for rats? I guess you could consider it for mice too, but for rats anyway, what kind of advice would you give them from everything that you know now?
Yeah, so a lot of it has to do with some of the limitations. So definitely do a pilot study first with your proposed post-op analgesic plan, because our findings only applied to Sprague-Dawley females that are 8 weeks old, specifically with bup, ER, or Meloxi R, and for a midline laparotomy procedure, and at a 30 mg per kg dose. So as mentioned earlier, if you're using Sprague-Dawley rats, I would caution using buprenorphine as the main analgesic, especially if you're relying on injectable ketamine to maintain anesthesia, because just the amount of self-trauma and pica wasn't great. But of course, consider your experimental design, since the aberrant effects of ketamine wouldn't be ideal if you're going to be doing a behavioral study right after they recover. They'll be constantly going. If you're doing a grip, you might not be actually studying for what you want to be. You might just be studying this is what ketamine does.
Yes, right, exactly. Good point. Yeah, very good point.
Or if you want the animals to take it easy after an orthopedic procedure, they'll be constantly walking.
Another good point.
It's mostly experimental things. If you're doing a long-term study looking at chronic pain, probably just avoid ketamine because it might reduce chronic pain. But if longer-term chronic pain is a potential negative side effect of your paradigm that you'd like to minimize, it could be beneficial. It's also, of course, possible a lower dose might work, 10 mg per kg, but essentially do a pilot study. That's what I would say.
I love that. That is an excellent answer, and I don't always hear that answer. I think that's a very logical first next step. So I appreciate that. Well, thank you so much, Rachael, for being here. I know it's always hard to kind of just jump in, and especially when it's early morning there for you on the West Coast there. So I so appreciate you taking us through your paper. Excellent work. You've got a great team there. And you've contributed and greatly moved the science forward, and we really appreciate it.
Oh, thanks so much. Thanks so much for having me.
Of course. Thanks for joining us on this episode of The Last Word. We'd love to hear your thoughts, so be sure to leave your feedback in the comments. And don't forget to subscribe for more great content. We encourage you to submit your research manuscripts to our journals, JAAALS and LAS Pro. We're always looking to feature impactful studies. You can also connect with us on our social media channels or email us directly at info@aalas.org. We appreciate your listening today, and we'll see you next time on The Last Word, an AALAS podcast. Until then, stay curious and stay connected.